we'll go ahead with the next talk by Dr. Jagdish Rana. And Dr. Rana is going to speak on management of armored cataract. Dr. Rana, your
Yes, sir.
presentation is ready now? Yeah.
Mm, mm, it is not. It is going on. I think it is starting with,
Video. Yeah.
yeah, it's, yeah, this one. Should I start from here?
Yeah.
This one. Okay.
Left bottom. No, no. Don't
This
close
one.
that. डॉक्टर राणा आप पहले खोल लो इसको खोलो ओपन इट हाँ
Yes. Okay.
हाँ फुल स्लाइड मोड कर लो हाँ अब आप इसमें इस वीडियो में नीचे देखिए लेफ्ट कॉर्नर में बैक बटन है नीचे बिल्कुल और नीचे जाओ बिल्कुल लेफ्ट कॉर्नर बिल्कुल लेफ्ट कॉर्नर नीचे कॉर्नर में बैक बटन है उस बैक बटन में जाओ
This one.
बैक करो आप बैक अगेन हाँ अब चलते जाओ बैक उस स्लाइड पे आ जाओ
Yes. Okay. It's okay, no? Yeah.
और पीछे जाओ फर्स्ट स्लाइड नहीं आई है आपकी अभी ये आ गया बस ठीक है स्टार्ट है
Yeah, first, yeah, okay.
ठीक है
So, good evening, friends. So, I am at the outset, I am thankful to Dr. Rajendra Prasad for giving me an opportunity to present my topic on management of a armored sector. So, why it is not moving? So, I should start with a, it is not moving, I don't know.
फॉरवर्ड से नहीं हो रहा है फॉरवर्ड बटन से
Actually, this is going, yeah. So, I will start with a small funny video. So just like a armored cataract, this is a armored lady. Audio is coming, sir.
ऑडियो
This is the armored lady where our tradition. Audio is visible or not, sir?
ऑडियो इज नॉट
So should I go back again? Or okay.
गो बैक यू कैन गो बैक और उसमें ऑडियो आप अपने कंप्यूटर से ऑडियो इंक्रीज कर दो
So stop. Should stop there now. Okay. Okay.
Yes.
So this is already where our traditional weapons are not effective. So just like a armored lady, we are also dealing with the armored attack. So we are the box. So why there is an armored attack is important because it's attack with positive Sanikia, it's armored with a positive Sanikia, where traditional measures are not effective. So often a challenging condition and often associated with interoperative and postoperative complications. So the cause of the attack in this type of attack is intraocular inflammation, chronic corticosteroid usage, and there can be both of the reason. The successful surgery in this case stems from the careful patient selection and detailed patient counseling. Also, meticulous and careful cataract surgery is essential with in-the-bag IOL implantation. Aggressive pre and post-operative control of inflammation is very much important. And the anticipated management of post-operative complication, especially glaucoma, is better. It's earlier rather than the later is very much important. Let me go to.
आप नीचे से ही फॉरवर्ड कर दो डॉक्टर अना, नीचे से जहाँ पे उस कॉर्नर में ना, नीचे कॉर्नर में एक फॉरवर्ड वाला बटन भी है, वहां से फॉरवर्ड करो।
हाँ
इसके आगे, हाँ यहाँ से करो।
हाँ ठीक है। So careful pre-operative assessment is very much important to look for the cause of the posterior synegia, to look for the scar and keratopathy. If you look in the iris for the atrophy, whether the IOP is high or low. Status of the macula is very important. Like so, look for the ischemia, atrophy, edema, CNVM, or it carries a prognostic. And the optic atrophy and the severe cupping of the disc has a bad prognostic sign. And should also look ischemia and detachment. The preoperative investigation routine includes preoperative minor profile, physician fitness certificate, and the tuberculosis or rheumatoid arthritis and the other granulomatous disorder for the cause of the surgery should be delayed until the antechamber is free of cells, but the flare may persist. And when to do the surgery, friends? So it should be inactive for at least 3 months prior to the surgery. It increases the risk of postoperative cystoid macular edema. Topical and systemic steroids should be used prophylactically for 1 week prior to the surgery. It should be continued post also. Immunosuppressive drugs may be. So 1 gram IV MPS methylprednisolone should be used a day before the surgery in cases where the despite of very heavy immunosuppressant inflammation is not completely abolished. When the surgery is urgently required in case of uveitis with the type of the IOL, as we know, monofocal IOL is very much important. Single piece square edge acrylic hydrophilic or hydrophilic lens is important. Multifocal IOL is maybe it may compromise sensitivity leads to rather increase in the contact sensitivity, and accommodative IOL is not indicated because of in this type of cases it leads to the scarring of ciliary body and progressive fibrosis. So intraoperative complication includes the zonulolysis. This is a frequent complication which encounter in case of the chronic uveitis, and retained lines and the nuclear fragments which may pop up into antechamber a month later from the antechamber and leads to recurrent inflammation and local corneal edema. So post-operative complications of intraocular inflammation, IOP rise, posterior capsular opacification, cystoid edema, submacular fibrosis, epiretinal membrane, IOL deposits, IOL decentration, anterior capsular fibrosis, and choroidal effusion hypotension. This is the complete list of the complete. The three most frequent causes of poor visual recovery are cystoid macular edema, and epiretinal membrane. This is one of the video which I operated with in case of annular posterior synechiae, a armored cataract. So I have injected the oculon inside, Jalocard inside the antechamber, and I injecting a viscoelastic. Now I'm doing a posterior synecholysis with a iris suppositor, trying to remove all the synechias from both the side port wound before creating a wound. So at that time, the deep antechamber is must. Now applying iris to expose enough of the anterior capsule. Complete TCC is very much important because we need to have a IOL in the bag. So after complete capsulorrhexis, multiple head dissection is multi-quadrant head dissection very good to avoid a jonular stress. This is multi-quadrant head dissection, and now I am the emulsification. In this case, I am using a double-tooth PHACO chopper. It's very important PHACO chopper in such type of cases because it gives a less space over the PHACO chopper. I am doing rechopping. I am also rotating epinucleus also. Now I am cleaning the viscoelastic material from the anterior chamber also, as well as from behind the IOL. So it's very important step to evacuate the viscoelastic from behind the IOL to prevent the reactivation of a inflammation as well as to rise of the IOP post-operatively. This is the second video of a armored cataract. So again, after injecting a Jalocard into the anterior chamber to both the side ports, I am doing a posterior synecholysis. Because now the pupil is enough dilated, I am not applying iris hook. I think this much dilatation is enough for doing a rhexis and the PHACO surgery. So I am doing multi-quadrant head dissection again to avoid space over the jonules. Use my double-tooth PHACO chopper. So doing chopping with this double-tooth PHACO chopper, rotating it. Rotating is very much easy with double-tooth PHACO chopper because of double tooth. We have a controlled rotation and controlled chopping. Now again doing in situ chopping, not bringing the nucleus into the center. At the same time, PHACO emulsification is very easy. And now also fixating the eyeball with my double chopper, doing a bimanual to the cortical matter. As far as all the cortical fibers are, I can remove with a double tooth. This is a bimanual. So now injecting a single piece IOL. Here all I am removing after injecting into the bag implantation. I am removing viscoelastic from behind the IOL also. So removal of viscoelastic from anterior chamber as well as behind the IOL is very important step in this type of cataract. So this is the end result. I am doing a closing the IOL, closing the wound with a hydration. So the take-home message is, in case of a armored cataract or a cataract with successful visual outcome, with the important step is a careful patient selection and counseling, proper timing of the surgery, And then multi-cordon hydroresection and double tooth phaco chopper and other measures to prevent stress over the jonules are very much important to prevent the surgery. Meticulous cataract surgery with intrabrachial implantation is important, and close monitoring for the post-operative complication, including reactivation inflammation and rise of IOP, very much important. Thank you so much. Sir, sorry for the trouble in between, sir.
Thank you, Dr. Jagdish, and beautiful presentation.
Yeah.
See, you had a little net problem over there, so we were getting a little lag in the
Yeah.
video. But still, we could see very well, and you managed this post-uveitic cataract with the lot of synechias, and you have very nicely shown the videos and completed the surgery with very well successfully completed. Yes, Dr. Shishir, you want to make any comment on Dr. Rana's videos?
Unmute yourself, Dr. Shishir. Unmute yourself.
Yeah. Sorry, I joined late because I was in the other seminar, ARC webinar. So I saw the last part, wonderfully done surgeries. So I think, yes, the important thing being, breaking synechiae and dilatation. So I would usually use adrenaline to dilate, and you get a little more dilatation, it becomes more comfortable. And these cataracts usually so many times are not very hard. So once the initial part you do, synechia are released, and you strain the capsule and do a little bigger excess, and the cataract is, then it all becomes very easy. Case is well managed by you.
Thank you, sir.
Excellent presentation, sir. Sir, I would like to ask two questions. What are your experiences with the pre-op and the post-op use of topical NSAID? And the second question is the use of this heparin-coated hydrophobic ions in such cases.
So answering your first question, usually day before surgery, we start NSAID with antibiotic combination 4 times a day, and then before the surgery, half hourly 4 times, and then post-surgery I continue the same antibiotic with NSAID till the order completes. That is, and then with it I am giving the steroid antibiotic drops also for approximate in this 1.5 months doses, and looking. We have to watch the inflammation also. If the inflammation is patient is quite high, then I may try. Patient is quite, the inflammation cells are there, and then I may continue long. And I taper the steroid early, and then see the patient. And regarding the heparin-coated IOL, so I have stopped using since long. But in so many years, I have not used any heparin-coated IOL for in such type of cases. So, comment from others.
Dr. Shishir,
yeah, so we have now started using triamcinolone for last few years in cases where there is vitreous, to find out if there is vitreous in the anterior chamber. But in cases with these uveitis, where we expect there is going to be a lot of post-operative inflammation, I have been using a few crystals of tricot in the anterior chamber post-operatively, intraoperatively at the end, and you actually see a lot of difference in the outcomes, the post-op inflammation outcomes. It really helps. You are sure of your asepsis, and you put a few crystals of tricot in the anterior chamber at the end, and actually you get wonderful results. No harm at all. Been doing for last so many years, at least 10-15 years I've been doing this.
Dr. Shishir, IOP surge you noticed?
So normally in uveitis cases, it would not be there. Normally it is not there. And just a few crystals, and it does not actually happen.
I think it's a good idea by Dr. Shishir, like you put, although I haven't used yet these triamcinolone crystals in the anterior chamber during the surgery itself, because most of these cases, they respond very well with the topical steroid drops, because there is a well penetration of these topical. But I think it's a good suggestion, like if you put a few drops of triamcinolone during the surgery itself in the anterior chamber, you will have a more effective and quick effect of the steroid, like where you expect the inflammation in these cases. Dr. Javeri, you want to make, Reshma, some comment on this?
I think it was a very well presented one. Even I've never used these crystals, so I think it will be a good initiative for me also to start using them. Thank you so much for that input.
I think it's a good idea to use. It can help very well. Yeah.
It really helps actually.
Yeah.
One has
to be careful about steroid responders.
Yeah, that's right.
Yeah.
True.
So what I am doing is post-operatively, immediately after, because these surgeries are done under topical anesthesia. So I start using steroid drops 1 hour early, just immediately after the surgery. That is steroid 1 hour early. And if I predict that inflammation is there, I use cyclopentolate 4 times a day. So it helps in preventing inflammation because of the cyclopenia. That cell count rise is not there. Inflammation is also very much controlled. And then on Sunday, usually the inflammation is very much controlled. Yeah.
So with regards to the IOP, we have to be very careful as well. Sometimes in these cases, with a lot of post-op inflammation, sometimes the pupil gets stuck again to the IOL, and iris Bombay type of picture forms, and the pressure is not getting controlled. You do adjust little iodotomy, and the pressure is relieved. I've done it in a few cases, and really it helps where the iris has got stuck.
Most important in these cases is you have to take care of the inflammation, which you expect in most of these cases post-operatively, and the rise of intraocular pressure also has to be taken care of. So thank you, Dr. Rana, for a beautiful presentation. So we'll go ahead with the next presentation now. Next presentation is by Dr. Arvind Maurya. Dr. Arvind is going to present on combined phaco trap with Ologen in a one-eyed patient.
Good evening, my mentors and my friends. Thank you, RP sir and Elegant, for the opportunity. So it's a small video.
72-year-old male
diagnosed
with left eye nuclear sclerosis, grade 3 cataract with chronic angle closure glaucoma with no PL in other eye is planned for combined phacotrabeculectomy with Ologen matrix implant. The operative vision was 6/60 in left eye, and the maximum IOP is 43 mm mercury. The eyeball is deeply seated, and after giving peripulpal block, a severe subconjunctival chemosis happened. A superior rectus bridal suture was passed, and following which a conjunctival peritomy was done in a severe chemosed conjunctiva. After removing tenons, a wet-filled cautery was done to reduce the chances of subconjunctival bleeding. Following which, a limbal-based scleral flap, triangular in shape with apex reaching towards the fornix, is made using 15-number blade. The scleral flap should be half thickness of sclera. The thin flap may cause a buttonholing of scleral flap. After giving the scleral incision, the scleral flap is raised till the corneal margin by using crescent. A side port entry into AC was made at 10 o'clock, following which air trypan blue dye was injected and it was washed. The AC was reformed using viscoelastic substances. A continuous curvilinear capsulorhexis was done using 26 gauge hypodermic needle. The capsulorhexis was quite difficult in this case due to small pupil as well as shallow AC. In these cases, The viscoelastic substances should be used little or in moderate amount for formation of AC before doing capsulorhexis. A main port entry was made using 2.2 mm of keratome at 12 o'clock beneath the scleral flap, following which hydrodissection and hydrodelineation were done. Floppy iris was noted. The nucleus was maneuvered and rotated using a Sinskey hook. The pupil was further constricted and the subsequent steps become quite difficult. Iris prolapse was noted and it was repositioned using iris repositor. A cohesive viscoelastic substance was injected in AC in little to moderate amount for AC deformation. The PHACO emulsification process was started by using PHACO probe and the chopper. First, the nucleus is divided into two pieces. A sculpt was made. Thereafter, the PHACO emulsification process was completed by direct chopping technique. The PHACO emulsification parameters were kept in the lower range due to small pupil and shallow AC. The cortical matter was removed using Sinko's cannula. During irrigation and aspiration, a sudden bradycardia was noted and was managed appropriately by anesthesiologist. A foldable posterior chamber intraocular lens was implanted in the back. Viscoelastic substances were removed using Simcoe's cannula. Scleral flap was lifted and scleral piece above the trabecular meshwork is excised using MVR blade. Peripheral iridotomy was done. The prolapsed iris is repositioned using iris repositor. Corneal side ports were hydrated. Air is injected in anterior chamber for anterior chamber reformation and scleral flap is repositioned and sutured at apex using 10-0 nylon, followed by suturing at right and left arm of the scleral flap. An Ologen matrix implant was placed beneath the conjunctiva and the conjunctival closure was done using 80 Vicryl. Implantation of Ologen in the subconjunctival space offers a new opportunity to prevent the complication associated with mitomycin C augmented filtering surgery such as corneal endothelial cell loss, cystic thin avascular bleb, choroidal detachment and endophthalmitis. Moreover, Ologen is composed of porous matrix that can induce fibroblast growth leading to a well-organized and healthy healing process. and the remaining conjunctiva is closed cautery. Despite so many complications and difficulties during the surgery, during the post-op period, the patient's vision is improved to 612 and the IOP was reduced to 9 mm of mercury with a functional conjunctival bleb. Combined phaco-trap surgery in a case of angle closure glaucoma reduces the chances of chronic angle closure in 25% of cases according to some studies. 72-year-old Mick.
So thank you, friends. Thank you for your patient listening.
Arvind, exit. Thank you. Thank you, Arvind, for the wonderful presentation and wonderful video of phaco trap with Ologen surgery. And this is something which is important we have to look into, like when we are doing a combined surgery, especially phaco trap, then because through the trap you're taking the phaco probe also, so chances of inflammation is always higher in such situation where you are doing the combined, and then this high inflammation always may lead to the subconjunctival scarring and failed bleb, and your glaucoma may not be controlled. So putting an Ologen underneath the conjunctiva is one of the very important technique, and which Arvind has very nicely shown and very nicely done video. And I congratulate you for the beautiful and wonderful surgery.
Thank you, sir. Thank you.
Dr. Sandhya, you want to make some comment on this video?
I would say very nice presentation, very nice video you've shown. Actually, I don't have much of experience about it, so can't comment, but it seems a very good method.
Dr. Shashir, are you always doing a same port combined phaco surgery, or different ports for two different surgeries in the same sitting?
So I normally prefer a different port surgery, and so many times, like a very well done case, Dr. Arvind. So these patients are usually so grateful, like one-eyed patients from villages. It is always good to do a TRABI and cataract whenever required. So many times I would just do a TRABI in end-stage glaucoma one-eyed patients, and in a second stage do a cataract surgery. But then when required, of course, but I do with different places, TRABI at a different place and phaco at a different place. Usually.
Dr. Reshma, doing situation.
Yes, as Dr. Sheshir just mentioned, even I'd prefer to do it in two different sites. Same time, but at two different sites. It's a beautiful surgery, Dr. Arvind. I loved it.
Thank you.
About Ologen, I have used a couple of Ologens earlier. Things that I used to face that time is I saw the bleb that were, I thought the blebs were much bigger. And it was not easy. So if there was a pressure that is raised, it's not easy to really, open up a suture, or we have to, and it dissolves over a very long period of time. And sometimes it doesn't even dissolve. It's there for a long time. So these are the couple of things I used to face when I used to put Ologens. I've stopped using Ologens now. But yeah, so any comments on that? That do you also, face all of these?
Yes, I have faced a few of these things. So in those cases, we can use these adjustable sutures.
Correct.
That fares very good.
The only thing that we have to use sutures. Yeah, but if I had to laser it or something, if it's a fixed suture, then it's very difficult.
Which Ologen you use? The size of the Ologen implant pulse you used in few cases, no?
Yeah.
What was the size of the implant?
It was the smaller between the two. I don't exactly remember the size because
So the smaller one is more thicker. So what you can do is you can use the 10:1. So that is thinner. So
Yes.
that will, so that will help.
But it's very important to put the Ologen actually, because if you're doing the combined surgery and on the same port, but I normally practice same port surgery only. I never did any different port surgery. I go through the same port and with the Ologen implant and or MMC, what it is like, but it works very well from the same port also.
Yeah, especially in the pediatric, these glaucomas, the Buchthelmos and the Exenfield Rieger cases, this Ologen works very well.
Yeah. So thank you, Arvind, for the beautiful and wonderful presentation. And we will go ahead with the next presentation, which is, I think, the most important one, because we keep doing surgery and then we, many times we forget about the post-op infection and during the surgery, and then when we have to tackle the post-op infection, and if you, in any case, you get the post-op infection in post-PHACO, then it becomes really difficult to manage and really difficult to convince the patient that you have the post-op infection. So why not to prevent it pre-op, the post-op infection? So Dr. Tushar Grover, he's going to present a topic which is called as a resistant towards resistance. So Dr. Tushar, the dice is yours now.
So good evening, and my sincere gratitude to Dr. Rajendra Prasad sir and Elargan for having me. So I'll just share my screen. Is my screen visible?
Yeah, it's visible.
Okay. So the topic, so some wonderful surgical videos have been presented and it's been great learning for me. And I'm thankful to you all for that. And I'll just be deviating a little bit from that and moving towards a slightly more boring topic of antibiotic resistance. So antimicrobial resistance was touted as the next big pandemic before COVID took its place. And it's contributed by a variety of factors. I mean, indiscriminate use of antibiotics on humans, on animals, the use of various kinds of biocides in agriculture, and in the environment by the whole variety of pharmaceutical waste that is generated, by the hospital waste that is generated. So all of that has created this huge problem of antimicrobial resistance. And India has been reported in studies to be the antimicrobial resistance capital of the world. So I'll be presenting in terms of 3 case scenarios of corneal infections, but all of these are equally applicable in any form of ocular infections because the situation remains the same and the problem of antibiotic resistance remains the same. So this was a very aggressive corneal ulcer that had developed in an infiltrate, which was otherwise clear in a healthy individual. And when we went for culture sensitivity, as you can see, it's pretty much resistant to all antibiotics. The only antibiotics that were sensitive in this case were gatifloxacin and fortified vancomycin. So that is what we went with. And slowly the patient did show improvement and finally this ulcer resolved. This is the second case scenario where this was a fungal corneal ulcer and culture showed fungus as well. But with antifungals as well, this just kept getting worse. And we really didn't know what to do when we did 3 scrapings on this. And the third time we found that it was a mixed infection with a rare organism and really again resistant to all the antibiotics. So when we had suspected a mixed infection, we had given fluoroquinolones, but as you can see that this is resistant to all fluoroquinolones. And so finally, we went with fortified cefazoline, and ofloxacin was the fluoroquinolone that it was sensitive to. So this is what we went with along with the antifungals, and finally the patient showed improvement. The third case scenario is that of an infection by nocardia in a corneal ulcer. And you know what we most commonly use for this is fortified amikacin because that really works very well. But in this case, as you can see, everything is resistant. I mean, even most of the fortified antibiotics are resistant, but in this case, fluoroquinolones were sensitive. So we treated with fluoroquinolones here and we finally got resolution. So the point that I was just trying to make is that drug resistance comes in, sorry, I'll just move back. Just a second, please. So the point that I was just trying to make is that drug resistance comes in various forms and we really don't know what antibiotics that particular organism is sensitive to and resistant to. The AO preferred practice patterns suggest that fluoroquinolone monotherapy is at least as effective as a combination therapy with fortified drops. But the limitation there is that there are no randomized controlled trials that have compared fluoroquinolones with fortified antibiotics. And the antibiotic resistance monitoring in ocular microorganisms surveillance program has shown that there is extensive moxifloxacin resistance that exists now. About 33% of Staph aureus, about 72.8% of methicillin resistant Staph aureus. And the situation is actually even worse, possibly in the Indian scenario, is what the data shows. There are similar trends that have been seen with antibiotic susceptibility in endophthalmitis as well. So the problem exists with all forms of ocular infections and systemic infections as well. There are some studies that have shown that gatifloxacin has been more sensitive to infections than moxifloxacin, because there has been more extensive abuse of moxifloxacin than any other fluoroquinolones in the last few years. And even in this particular study, it shows that for gram-positive bacteria, it was fortified vancomycin that showed the highest sensitivity, followed by gatifloxacin. For gram-negative bacteria, it was again gatifloxacin that showed higher sensitivity. And these are the drugs that have been recommended for multi-drug resistance. Of course, these are a last resort and in cases that don't respond to anything. So antibiotics like colistin, like imipenem, and linezolid. So these have been found to show response in the more resistant varieties of bacterial infections. So basically, what is really important for us is to prevent this problem. I mean, we can't prevent it completely anymore, but we can at least reduce the damage that this is causing to us and prevent it from getting worse. So one of the important things is to choose the right dosage. So if we give a very low dose of an antibiotic, say once a day or twice a day, that might not really be helping us get rid of any infection, but could possibly be inducing antimicrobial resistance. And again, tapering antibiotics with steroids would not be recommended. So when we reduce the steroid in an antibiotic combination, when it comes down to once or twice, that again might be promoting antimicrobial resistance. The other thing that's important is to use the right antibiotic. So as far as possible, it's important to isolate the pathogen that is causing the infection and then treat the infection according to the sensitivity of that organism. The drawback, of course, and the problem that we have is that these tests take time. But I mean, we have rapid tests that are becoming available. They're not extensively available right now, but hopefully in future, they'll help us make better and faster decisions. And the final important point is to use them when there is a tangible benefit. So for example, in viral conjunctivitis, which really forms 80% of the conjunctivitis, the use of antibiotics may not really be necessary. Even, I mean, the panelists would be the right people to give their opinions on this. But preoperative antibiotic prophylaxis in cataract surgery has also not been found to show a significant difference in most studies. And we might be better off using preoperative antiseptics such as chlorhexidine and povidone iodine. And these might be as effective and as useful and prevent the worsening of antimicrobial resistance. So to summarize my short presentation, antibiotic resistance is a rising concern and we are already dealing with it. India has been described to be the antimicrobial resistance capital of the world. Isolation of microorganisms with resistance tests should be what dictates which antibiotic we use. When we are going with fluoroquinolone monotherapy, gatifloxacin might be a more effective option than moxifloxacin because it has been less abused so far and shows relatively better sensitivity profiles. And the last important thing is to avoid indiscriminate use of antibiotics wherever we can avoid using them. So thank you. And thank you so much for having me in this meet. I've learned a lot from all the wonderful videos. So my sincere gratitude to all the speakers and panelists. Thank you.
Very nice. Thank you, Tushar, for the beautiful presentation. And your point was very, very important, like avoid using of indiscriminate use of antibiotics in your cases and pre-op, whether it's pre-op or post-op. You have to be very specific and very diligent to use these antibiotics in your cases. And the prevention of the infection in post-op cases is very most of these 3 cases where you had a permanent corneal ulcers and where you have to actually go in for the specific antibiotic, and for that you need to do the scraping and do the culture sensitivity, so you know which antibiotic is going to be more effective in such cases. So you have brought all these points beautifully. I have just a simple query, what about the intracameral antibiotic injection? Because we tend to avoid pre-op, because I'm not using any pre-op antibiotics now these days, but I use in all my cases intracameral antibiotics. And oxyfloxacin I use normally. And this, because now there is a lot of the reason for to use this, because in our Indian scenario, there have been a very big study from the Arvind Eye Hospital where they have where they have found it's very effective to prevent the intra-op infection. And what do you say, Tushar? What is your comment on this particular?
I agree, sir. I completely agree. Intracameral antibiotics has extensive studies now. There is a lot of data with huge sample sizes, which has shown that it is effective in reducing the incidence of endophthalmitis. So there, I think it is definitely, there is merit in using antibiotics. But preoperative, I believe there is not enough evidence yet.
At your center, sir is using in all the cases?
Yes, sir. He's using. I'm also using intracameral antibiotics in all my cases.
Okay. Dr. Arvind?
We did one of the randomized trial between this intracameral moxifloxacin and the placebo. The saline was pushed into the anterior chamber. And there was no significant PL. There was no difference in both the groups. And it was over 100 cases and in each group. So there was no difference. No, definitely.
What do you say? What is your experience?
So it's betadine is doing fine with us. So we are fine with betadine.
Yeah. Dr. Sandhya, are you using intracameral antibiotic?
Yeah, actually, in initial days, there was a time when I was using it, but now I've stopped using it because somehow I feel that our pre-op sepsis has become quite better. I'm using routinely betadine in the tyrophonics. I put it for some time, and I've seen in my cases that infections, I'm able to drastically reduce chances of infections in my cases. And Tushar, like you pointed out very nicely, that indiscriminate use of antibiotics is definitely a concern. So preoperatively, what antibiotic you suggest? I mean, I think then we should propagate that this point to everyone, to all the ophthalmologists, maybe through our bodies, maybe our ophthalmic societies, and everyone. We should, send them a kind of that what antibiotics we should be using preoperatively.
Ma'am, preoperatively, I would suggest, based on the data that's available, that we should not be using any antibiotic because there is no evidence in favor of it. The use of povidone iodine and betadine, of course, immediate preoperatively definitely helps, and there is evidence towards that, but really not much evidence for preoperative antibiotics. So we might not be helping in preventing any infections, but might be aggravating the problem of antimicrobial resistance here. So I would suggest no preoperative antibiotics.
You're right that pre-operative I mean, just before the surgery, povidone iodine is doing wonders. It's nothing better than that. But I think if we give away this message that preoperative antibiotics is not required, because see, you are sitting in a metro city, but there are a lot of people who are operating in maybe some suburbs or villages or small cities. You don't know the hygiene of the patient, where the patients are coming from, what scenario, what background, and sometimes they really have a very poor hygiene. So I think we should not give away totally this kind of message that preoperative antibiotics is just not required. We do need to, in our scenario, in our countries, this doesn't work.
Okay, that's right. Dr. Sandhya has put forward a very valid point. Like, we should not send the message like all the cases should not be avoided from using the preoperative antibiotic, because there are a lot of places like people are still using preoperative antibiotics, and it depends on the experience, like how you experience in your particular cases. Because I have an experience using preoperative antibiotic doesn't help, but using intracameral antibiotic injection definitely helps. and it's been published and it's been verified also. Dr. Berwa, are you listening? Dr. Berwa, what is your practice like at your center? Are you using
Yeah. For us, betadine, a day prior to the surgery and on the day of surgery works well. And antibiotics, we use detrifloxacin for 3 days. And intracameral antibiotics, I don't use. I have not used so far.
But you are using a pre-operative antibiotic.
Yeah, we are using for 3 days.
This would probably be a good survey to do as well, and maybe see the trend and what ophthalmologists believe, and that will be an interesting thing to find out as well, I believe.
This point was discussed few years back in Delhi Ophthalmic Society annual meeting, whether to use antibiotic or not, whether to use intracameral antibiotic or not. See, my point is that if you put topical antibiotic, the aqueous concentration is already 80 times the MIC 90 values. If you put intracameral antibiotic, it reaches 1,000 times. So when we are already crossing MIC 90 values 80 times by putting topical medication, having intracameral antibiotic will give you only the psychological advantage. So once I'm not convinced about this, actually I have never used intracameral antibiotic.
See, definitely, because what you are saying is also correct, but the experience is very important, because I have been using intracameral now for the last 13, 14 years, you can say, almost. And before that, before I started intracameral injection, I used to get endophthalmitis once in a while, like once in a 6 months or so, but then you get devastated because when you get the post-operative endophthalmitis. But believe me, since I started using intracameral, now it's 14 years, I haven't got a single endophthalmitis to date. So this verifies to me like it definitely works. It's not
the trick. The trick is, as one of our speakers said,
is if you get endophthalmitis, so that will may nullify the whole career actually, because the patient may take you to anywhere. So these days it's getting very difficult, because from that point of view also, I think one should use intracameral antibiotic injection, and it definitely works. And you go through the Urban Eye Hospital's study, they have done 1 lakh cases and they have 100% found it's effective intracameral injections in the prevention of the endophthalmitis. So I think thank you all panelists and speakers, and it's been a very great evening today. And thank you everyone, and I appreciate you being here. It was a totally thrilling experience with all of you. And my special thanks to Allergan India Pharmaceutical Limited, and they have a lot of effort in bringing out this webinar successfully today, and especially Mr. Samir. He has done a lot of work to been meeting me very frequently, and he has been very active and very cooperative in bringing this webinar live today. And thank you very much, and thanks again for joining us, my audience and all of you. And happy Holi to all of you, and my good wishes for the coming year. Thank you very much. Thank you.
So happy Holi to you as well, and to everyone.
Yeah, okay.
Thank you.
Thank you, Dr. P, for a wonderful platform. You had all of us together, and it was a wonderful webinar. And we congratulate you, and all the best to you all, everyone, and have a happy Holi.
Thank you, Dr. Sadda. You were our panelist.
Thank you for
Thank you so much.
Thank you so much, doctors. Thank you.
Thank you.